Good evening, aspirants. Today's class is on rheumatology. It will be taken by Dr. Varun Pushkarna. Sir, you can start taking the class.
Good evening, aspirants. Last time we covered until.
Good evening, sir.
Good evening. Last time we covered until scleroderma. So we'll take up another topics now. We'll begin with gout. Now, gout is very important. Gout and pseudo gout. These are basically classified under which kind of arthropathy? Anyone?
Crystal arthropathy.
Yep. So it is basically a crystal arthropathy, and in some patients and in some scenarios, it is usually asked as monoarthritis. So usually it is classified under monoarthritis and crystalloarthropathy. So gout is a crystalloarthropathy due to deposition of monosodium urate microcrystals within or near the joints. So it's not necessary that it should be inside the joint, it can be near the joints as well. It is usually caused by chronic hyperuricemia, that means uric acid levels more than 450 micromoles per liter. And essentially it is due to some secondary effect of a drug that decreases the renal excretion of uric acid, or it is because of CKD. In chronic kidney disease also, the excretion of uric acid is decreased. Uric acid is formed from purine metabolism. So it is a byproduct of DNA denaturation. It usually causes monoarthritis. Most common joint to be involved is the big toe of MTP in more than 50% joints, 50% cases. It is indeed the most common inflammatory arthritis in men and women above 60 years of age. Now, as I told you, uric acid is byproduct of purines. So the hyperuricemia can occur as an imbalance between uric acid production. Now, purine degeneration occurs whenever you are treating a solid cancer also. Solid cancers, bone marrow tumors, hematological cancers. So whenever you are treating them, the damage of the cells at a large scale leads to destruction of DNA at a large scale. So this leads to obviously more uric acid formation. That is why when the patients of these kind of malignancies, when they are started on chemotherapy, the uric acid load suddenly increases, leading to gout, and sometimes uric acid encephalopathy also occurs. So the uric acid production is increased in malignancies, and specifically when the malignancies are treated by chemotherapy. And the second reason is when the excretion is decreased. So whatever is being produced will accumulate gradually and gradually because the excretion is decreased, leading to symptoms of gout. So what are the increased production of uric acid syndromes? So one is the cancer, second is cytotoxic drugs, then severe psoriasis, any autoimmune disease which is very, very aggressive, they can lead to this, and Lesch-Nyhan syndrome, beer, even non-alcoholic beers, they can lead to hyperuricemia. Can anyone tell me what is Lesch-Nyhan syndrome?
HGPRT deficiency, hypoxanthemic hypophosphatasia.
So, okay. So
Sir,
you tell.
HGPRT is deficient.
Okay. So there is HGPRT depletion. What kind of depletion? Depletion means it was present earlier on.
What's the question, sir? Sorry.
What is Lesch-Nyhan syndrome? Very important. There are many patients in UK who have Lesch-Nyhan syndrome.
Hyperuricemia. Hyper.
So, as you are saying, it is HGPRT is what? Deficiency or depletion?
Depletion.
No, it is a deficiency. See, it is a X-linked recessive disease. So the gene is deficient, thereby the enzyme is not formed, leading to accumulation of uric acid. Are you getting it?
Yes, sir.
Yeah. So
Yes.
now you have to understand that this is a complete deficiency. This is a complete deficiency. Can somebody tell me what is the disease with partial deficiency of HGPRTase is known as? Can anyone do that? It is very important. Many times I asked this question. This question had come to me when I was giving MRCP exam. Any
Sir,
idea?
sir, Kelly-Sigmiller syndrome.
Wonderful. So it is known as Kelly-Siegmiller syndrome. It is the younger brother of Lesch-Nyhan syndrome. Now, there is a partial deficiency. Do I have a space? Yes. So, there is a partial deficiency of HGPRTase, that is hypoxanthine guanine phosphoribosyl transferase enzyme. Now, this is involved in the metabolism of purines. This also clinically manifests as hyperuricemia, uricosuriasia, which is lost in urine, gout, and urolithiasis. So typically you will have a patient who is like 28 years old male. They will be all male by
X-linked, sir. Yes.
it is X-linked recessive
X-linked,
disorder.
yes.
That is why. So it will eventually lead to many symptoms of Lesch-Nyhan, but not mental retardation. It is not seen in Kelly-Siegmiller. Self-mutilation is not seen in Kelly-Siegmiller. They are people who are walking amongst you and I, going to normal schools, normal intelligence, but they are suffering from defective metabolism of purines. Is that okay? Which are the drugs which lead to this? So diuretics, famous drugs leading to hyperuricemia, aspirin, cyclosporin, pyrazinamide, renal failure, alcohol, lead toxicity, and of course, Down syndrome. Clinical presentation. I told you it is classically a monoarthritis, usually recurrent. First MTP joint is the most common. This is acute gout. Then is chronic gout, that is gouty nephropathy. And it leads to deposition of the crystals in the Bowman's capsule, the tubules, and the interstitium. So everywhere uric acid is deposited, leading to stone formation eventually, that is nephrolithiasis. Then chronic tophaceous gout. So tophi are formed, articular, periarticular. Usually in the exam it is said that there are white patches on the skin which when pressed express white chalky material from them. This is usually the line which is mentioned in the exam. So don't get puzzled. What is it? It basically is the chalky material is the uric acid crystals mixed with the calcium they coming out. Now, because I told you it is basically a condition of monoarthritis. For example, a patient comes to you with a complaint of monoarthritis. What is the best step that you do?
Aspiration.
Yes. So you do a joint aspiration. Now, let us see the permutations. If the joint aspiration shows negatively birefringent, crystal shaped, needle shaped crystals, what is it?
No.
If it shows positively birefringent,
Soda gout.
rhomboid shaped crystals, it is
Chondrocalcin. No,
it
rhombus.
should CPPD or
Soda gout.
pseudogout. Wonderful. So arthrocentesis is a definitive diagnosis for all monoarthritis. This will show negatively birefringent needle-shaped crystals under polarized light. Radiography will show large punched out cystic erosions in gout. Can you tell me which are the erosive gastritis? In the last lecture we read about it. Erosive arthritis. Number one is rheumatoid arthritis. What about SLE?
No, it is not erosive.
Wonderful. So, in the exam, you will need to differentiate rheumatoid arthritis from SLE. I will give you a case scenario. Sorry if I keep going back because rheumatology is a comparative topic. Unless you know how to compare between two things, you may be lost. So, usually the question comes like this, that there is a 50-year-old female coming with polyarthralgia, skin rash, leukopenia, all the small joints of hand and feet are swollen and tender. X-ray of hands shows erosions, periarticular region. ANA is positive. Rheumatoid arthritis factor R factor is positive. NT-CPA is positive. What is the diagnosis? First answer will be SLE. Second will be rheumatoid arthritis. Third will be Sjogren. What is the answer?
Rheumatoid arthritis.
Rheumatoid.
Why?
Anti-CCP antibody is positive.
Yes, and also there is erosive periarticular region.
What about ANA?
ANA may be positive in rheumatoid also.
What fraction of patients?
30% to patient.
Up to 15% of patients of rheumatoid arthritis can have positive ANA.
Sir, why there is a skin rash?
Rheumatoid arthritis can also have rash.
Yes, if there is splenomegaly.
Okay, sir.
So rheumatoid arthritis can have rash because of small vessel or small vessel vasculitis usually. Okay?
Okay, sir.
Okay. So, coming back to osteoarthritis, this is also an erosive arthritis, but the erosions are cystic in nature. Okay? And more so, it is a monoarthritis. Not all the joints will be involved. So, there are cystic erosions on the X-ray. Uric acids, usually during acute attack, are normal in 30% of the patients. That means even at a normal uric acid level, you can diagnose gout. Acute gouty arthritis, you can still make a diagnosis. Treatment, you should let it resolve unless it doesn't add diclofenac, drug of choice. NSAIDs. This is drug of choice. And sometimes you might need, along with that, intralesional steroids. There is a question which had come in MRCP, and I'm still so fond of that question. I keep telling everyone, I'll just write it down here. I haven't written it in the questions. I'll tell you. So there is this guy who had come with a monoarthritis of knee joint. Joint aspiration showed negatively birefringent needle crystals, and the patient has acute gout. The patient was started on diclofenac plus colchicine and diclofenac, colchicine and some aspiration was also done? Very interesting question. Now, this patient comes back after 7 days with same problem. No improvement. What are you going to do? Run your horses. Say anything.
You
So
want to
aspiration and culture.
Aspirate,
Say-
aspirate and culture.
septic.
Say again.
Aspiration and culture.
Yes. No culture. No culture.
Aspirate, only aspirate.
Purely aspirate.
Aspiration.
Just aspirate. There are crystals inside the joint. The crystal load is very much. That is why the patient is not improving. Because where does colchicine act? Anybody? What is the
The
mechanism of
neutrophil
action? Say again.
is
It's micro
reduce
polymerization.
Somebody is wonderful. Microtubule formation of spindles is inhibited. That means it can only stop further making of uric acid because of spindle formation is not there. So can you imagine that initially the purines that were made for spindle formation, they will be destroyed and there will be increase in the uric acid formation?
Yes, so more uric acid will be there.
Yes. So initially these patients can have actually worsening of the gout. So what will happen? The crystals will be even more. So there was no intralesional steroid in that answer. The other answer was start the patient on allopurinol. That was also not the answer. Start the patient on febuxostat. That was also not the answer. Sorry, the calls are coming. I don't know why so many calls are coming. Okay. So the answer was simple knee aspiration. Aspirate as much crystals you can aspirate from the joint so that the joint, because it is the crystals which are causing the inflammation. No, you take out the crystals, there will be no more inflammation. Is that clear?
Okay, sir.
Yes. All right. So this brings to me a very, very important question. There was another question that a 60-year-old man with gouty arthritis and coronary artery disease with LVEF of around 50% on diuretics has persistent symptoms. Number one, the patient is on allopurinol 100 milligram 3 times a day with no major relief. So patient has chronic gout with no major relief. What is the next best step? Number one, increase the dose of allopurinol. Number two, shift to febuxostat. Number three, give rasburicase. Number four, decrease diuretics. Number five, intralesional steroids. The EF is around 30%. Yeah. So tell
Sir,
me
So
what.
increase allopurinol. Number one.
Dose of allopurinol.
Sir, you wanted the best choice or wanted two choices that you can reduce the
You can
diuretic
500.
or give rasp.
So what is the most correct answer?
Probably
Rasburicase.
I go for decreased
Okay.
diuretic.
I will give you the best answer. No problems. What is the this nice guidelines for management of chronic gout? Start at allopurinol 100 milligram per day. This is the drug of choice. I'll tell you a very interesting thing in the meanwhile, during the course. Allopurinol 100 milligram per day is the starting dose. You go up to 100 milligram 3 times a day. The patient is already on 100 milligram 3 times a day. The next guideline is do not stop allopurinol until the maximum dose is achieved. What is the maximum dose? Anyone?
So 900 milligram per day.
900 milligrams per day. So the dose is 300 milligrams 3 times a day.
Okay.
Another interesting thing, iske niche the next guideline is febuxostat is another allopurinol, like it is this xanthine oxidase inhibitor. Another xanthine oxidase inhibitor which has a marketing approval for allopurinol resistant gout. Now, this changes the way you think. Febuxostat has just a marketing clearance, and that too in which patients? In allopurinol resistant cases. That means unless you have given the patient 900 milligrams of allopurinol per day, you cannot start the patient on febuxostat, unlike what we do in India. Here we start the patient directly on febuxostat. But that is now how MRCP will take the question. Is that clear?
Yes, sir.
Yes, sir.
Okay, sir.
So that is a practice changing definition for you.
Sir,
Yes.
sir, can I ask one question, please,
Yes, please go ahead.
related to this? Sir, I am doing DM critical care in a final year exam going. We are seeing the oncological emergency like tumor lysis syndrome, or sometimes some isolated uric acids are high. At that time, can we use
Yeah.
the febuxostat or something else we have to use, like isolated uric acid is high?
Very nice question. So
I think raspberry case is the drug of choice.
yeah, what is the cause of tumor lysis syndrome? Only then we can reach the answer.
Yes, sir.
What is the cause of tumor lysis syndrome?
Like uncontrolled growth of cells, na, sir. Like that's why the purine metabolism is more and uric acid levels are high.
Uncontrolled what?
Like growth of cells, like it's a more common
No,
in
no, no, no,
hematological
no, 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 no,
It's
no,
more
no.
destruction of cells.
It is destruction. It is the
Yes,
tumor lysis, not tumor growth syndrome. It is
Yes, sir,
tumor
yes, sir.
lysis syndrome. It happens when you give chemotherapy,
Chemotherapy.
which is tumor-cidal. So when so much of purines are released, immediately our body upgrades the xanthine oxidase job, and there are a lot of uric acid crystals. Uric acid is formed, but then it crystallizes because it is excess. Now, it is the load which is there. The enzyme is working day and night. And in fact, resburicase has to be started before giving chemotherapy. It gives more better results. But even
Yes,
if you have not given it before chemotherapy, give it as soon as possible. And remember, it is an acid which gets crystallized in an alkaline environment. So avoid the pH, avoid the blood to become alkaline. The more alkaline the blood will be, more crystals will be formed. Are you getting my point? So keep the
Yes,
patient hydrated, keep the urine flowing, and yes, and stay away from over enthusiastic correction of the metabolic acidosis.
yes, sir.
Do correct hypocalcemia because it will be there. And resburicase is the drug of choice.
Okay.
All of the other drugs will need their time. They are what do you say? Competitive inhibitors. So competitive inhibitors have no reputation in the world of chaos. They will be overturned by the excess amount of uric acid.
And how much dose to be given, sir, for resburic?
That is a class for matter for some other day.
Okay, okay, sir. Thank you.
Yeah. Okay. So immediately you give cocodamol and resburicase, which is discussed. So prevention of recurrent attacks. What is the indication to start allopurinol? Anyone? So
After
it is
first attack.
more than 2 attacks within 12 months. But there are certain other indications where you can start after the first attack, where there are visible tophi. That means acute on chronic gout. Or wherever there is kidney impairment, because the kidney cannot take out the uric acid. It's not working that well. Where you cannot stop diuretics, where the patient already has uric acid stones. So these are the only indications where you have to start it after the first attack. Otherwise, indication is to start the allopurinol when more than 2 attacks have occurred in the last 12-month period. You should not start allopurinol until 2 weeks after the acute attack has settled. Why? Because it will again push the patient to prolonged acute attack. It can precipitate acute attack. Always use NSAIDs and colchicine during first few months with xanthine oxidase inhibitor. Target levels are to bring it down to 0.3.
Sir, if the patient is on cytotoxic drugs,
Yes.
when to start? That's two after second attack or you with the first attack? After the first attack.
If the patient is already on cytotoxic drugs,
Yes, sir.
so yeah, that will become an indication to start allopurinol right away.
Okay.
Yes. Then you can use old drugs like probenecid or uricase agents like resburicase. That is a recombinant uricase. Pegloticase. These are recombinant urate oxidase and used in the acute settings. So this is the only drug that can be used in acute setting as a direct uric acid inhibitors. Now, how do these drugs they act? Resburicase. This is the mechanism. It converts uric acid to allantoin. Allantoin is highly soluble in water. So rapidly lowers uric acid levels, rapid regression of tophi, used in prevention and treatment of tumor lysis syndrome and can also be used in resistant gout. It allows allopurinol to be started without worsening of symptoms. Likewise, you said, if the patient is on cytotoxic drugs. So it helps if the patient was already started on resburicase. Okay. Now, monoarthritis, which is an extremely important differential for gout, starts with septic arthritis. So this is highly important diagnosis. Again, arthrocentesis is the step of choice. You will have more than 50,000 cells per microliter and gram stain may be positive. Pseudogout, we discussed, there is deposition of calcium pyrophosphate crystals, CPP. It gets deposited, becomes CPPD. Weakly positive birefringent rhomboid crystals under the polarized light. Lish-Nyhan syndrome, X-linked recessive, mutation of HPRT1, males are symptomatic, deficiency, that is complete deficiency. Gout, renal failure, learning and behavioral difficulties. Allopurinol has to be given lifelong. Same is Kelly-Siegmiller, but it is partial deficiency. There is no learning and behavioral or self-inflicted behavior. Gout and renal failure are there. Allopurinol has to be given lifelong. Pseudogout. Microcrystal monoarthritis, calcium pyrophosphate. Joints involved are usually knees, shoulders, and wrists, most commonly involved. X-ray shows chondrocalcinosis, which is called linear calcification of articular cartilage. Arthrocentesis diagnostic. Many conditions like hypothyroidism, hyperparathyroidism, hemochromatosis. Hemochromatosis is a very important differential of mono and polyarthritis. acromegaly, Wilson's disease, hypomagnesemia, hypophosphatemia. Please remember them by your heart because this is asked in the question. Investigations are transferrin saturation, ferritin levels. Treatment is non-steroidals, colchicine, and steroids, which can be given intra-articular, intramuscular, or oral. Very important. Okay. Hemochromatosis. Please, this is also studied in clinical studies, clinical exam, but it is also important from rheumatology. I will not go into the details, but you have to remember that hemochromatosis should be triggered in your mind if there is polyarthralgia, mimicking rheumatoid arthritis, plus the patient has diabetes mellitus. This is very important. So they may ask you which gene is involved. There is a classical X-ray finding in hemochromatosis, that is hook-like osteophytes. This is very important. You must not forget this. Okay? All right. We will not go into dermatomyositis right away. We will go into monoarthritis. That is my library that I have made. Where is monoarthritis? Yeah, classification of arthritis. The chapter of gout and pseudo gout cannot complete without the classification of arthritis. Arthritis is where the inflammation of joints is there. It can be classified on number of joints and underlying cause. So that means monoarthritis, oligoarthritis, and polyarthritis. Underlying cause, any inflammatory, non-inflammatory. So you can define them in a broader perspective. Classified by underlying cause. So inflammatory arthritis, examples are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis. Characteristics are they are all autoimmune, usually symmetric, and having systemic features as well. Degenerative arthritis, for example, osteoarthritis, is usually caused by wear and tear, usually asymmetric. Whichever joint is used more will be affected more, and age related. Higher the age, higher the incidence of osteoarthritis. Infective arthritis, septic, Lyme's disease, wonderful. Lyme's disease is known by a rash which is known as
necrolytic erythema migrans. Necrolytic erythema migrans.
Yeah. So that brings me to something differential of it. Erythema marginatum. Can anyone tell me ये कहाँ मिलेगा?
Rheumatic fever. Rheumatic fever.
Rheumatic fever. And erythema multiforme.
And toxic epidermal necrosis.
That is drug reaction.
So drug reaction. 10. Simple streptococcal infection. Simple mycoplasma infection. Okay. Very good. You already know everything. Nice. Good. Okay. Metabolic arthritis, for example, gout caused by accumulation of metabolic products, gout and pseudo gout. Metabolic arthritis, hemochromatosis. Number of joints involved, monoarthritis, usually gout and septic arthritis, pseudo gout. Oligoarthritis, 2 and 4, psoriatic, reactive. Polyarthritis, all the big names, rheumatoid arthritis, SLE. Okay. What happens when you get it in the exam? Monoarthritis, immediately think of septic as 1, gout as 2nd, hemarthrosis or traumatic as 3, pseudogout as 4, and do not forget hemochromatosis as 5. Very important. Oligoarthritis, reactive arthritis, psoriatic arthritis, juvenile idiopathic arthritis. Not many questions are asked, but still, I may not take the class of JIA. It is a very big topic, cannot be covered, but I'll try if I can make a small lecture in the next class on juvenile idiopathic arthritis. It is very interesting, and sometimes you can get one question. Only the brilliant students will attempt it, and they will. Otherwise, most of the guys will try to leave it or mark it wrong. Very important, juvenile, because the guidelines are different. Polyarthritis, rheumatoid arthritis, and other SLE, symmetric, seronegative spondyloarthritis. So, whenever SLE is there, you always remember that it is non-erosive. Okay. How do you diagnose? Inflammatory markers are very important to differentiate from inflammatory to non-inflammatory. Specific antibodies like RA factor, anti-CCP, ANA. Imaging, X-ray, MRI, ultrasound for joint damage, bone scan for infection or metastasis. Now we come on to the practice questions. A 55-year-old woman presents with symmetric joint pain, morning stiffness lasting over an hour. Blood test shows positive rheumatoid factor and anti-CCP antibodies. What is the likely diagnosis? Easy. Cakewalk. Rheumatoid arthritis. So this is rheumatoid arthritis. A 45-year-old man presents to the emergency department with sudden onset severe pain, swelling, redness in his right big toe. He reports that pain started suddenly last night and has worsened. He cannot walk. He denies any recent trauma to the area. Past medical history is significant for high blood pressure and obesity. No known history of joint disease. The right first metatarsophalangeal joint is erythematous, warm, extremely tender. Temperature is 37.5. Lab studies show TLC elevated at 12,000. Serum uric acid level of 9.5. Normal renal function. Aspiration of the joint shows white blood cell count of 20,000. Negatively birefringent needle-shaped crystals under polarized light. What is the diagnosis? Gout. Easy. So, this is the classification of acute and chronic arthritis, monoarthritis. So, whenever you see monoarthritis, you can do this. You can draw a line and then monoarthritis can be acute, can be inflammatory, can be non-inflammatory. In monoarthritis, non-inflammatory, hemarthrosis and trauma are the most important reasons. Acute monoarthritis, crystal-induced septic gonococcal acute onset inflammatory polyarthritis can also present, but usually in MRCP, they will not confuse you with this. But these are the major four: crystal, septic, gonococcal. In crystal, gout and pseudogout. Chronic monoarthritis, tuberculosis is the king. So basically, it is a septic arthritis, but with a twist that it is a tuberculosis. Brucellosis, fungal, immunoinflammatory, crystal-induced can present as chronic. Non-inflammatory monoarthritis can occur in single joint osteoarthritis. There is a Charcot's joint. Can anyone tell me what is it?
Yes.
Diabetic.
So, severe diabetic neuropathy basically is a degenerative non-inflammatory. So, this is neuropathic arthropathy. This is Charcot's joints. Then, of course, osteonecrosis and other things. Okay. Let me come back to. So, everything is clear about monoarthritis and how to approach it.
Okay, sir.
Now, let's do other conditions which are important. but we have actually covered the most important ones already. Direct questions will not be asked, but then these will be in the relevance of things. I'll tell you, keep telling you along. Dermatomyositis should be studied separately from polymyositis. It is an acute myopathy characterized by proximal muscle weakness and rash. Why? Derma means skin, myositis means muscle. Both of them should be involved. However, polymyositis is basically symmetrical proximal muscle weakness plus muscle pain, myalgia, but no rash. Females are more, usually 30 to 50 years of age. If in children, the diagnosis changes, it is juvenile dermatomyositis. Now, you have to understand that dermatomyositis and polymyositis, this is the muscle fiber. So there are endomysial fibers and there are perimysial fibers. Should I change the color? These are the perimysial fibers. And these are the endomysial fibers. If skin has to be involved, the inflammation has to be in the perimysium. So that is why in dermatomyositis, there is perimysial inflammation. And it is antibody driven. These are small words which can make a difference. Antibody mediated. Whereas in polymyositis, the inflammation is in the core of the muscle. And it is cytotoxic T cell driven. Why I am telling you this? You will get biopsy results in the exam. In biopsy result, in dermatomyositis, it will be mentioned that you see inflammatory cells in perimysium. Nothing else will be mentioned. Whereas in polymyositis, they will tell you that there are T cells or cytotoxic cells in the endomysium. So this will differentiate between polymyositis and dermatomyositis. So dermatomyositis is antibody driven, perimysial inflammation resulting in muscle damage outside, on the outside. Perimysium being closer to the skin gets involved with skin, associated with complement activation and CD4. Polymyositis, T cell driven, endomysial inflammation, endomysium being farther from the skin, no cutaneous manifestation, associated with CD8, that is cytotoxic T cells. Very important. If a patient comes,
dermatomyositis is usually associated with CD4, right?
say again.
Oh.
Yes.
Okay.
So CD4 are required for B cell activation. No? So CD8 directly kills. Associated conditions. It is very important that a patient whom you have diagnosed as having dermatomyositis, then once you have managed the patient, the next best step is to get a CECT, abdomen and chest. This has come in the exam because they will tell you that the patient is diagnosed with dermatomyositis. What is the next best step when the patient is stabilized? The next best step is to find any occult malignancy. Is that clear? Which malignancies? Breast or ovarian cancer. Let us say a patient has renal dysfunction. The nephrologist has not cleared for CECT abdomen plus chest. What will be the next best investigation? There may be more. There can be more than one. So please mention. If you want to go to the depth of the case, what will you do? The patient cannot be taken for CCT.
The USD renal doctor.
Whole abdominal ultrasound, number 1.
Yes, sir.
Yes, sir.
Number 2,
Hello.
chest X-ray. Number 3, transvaginal ultrasound. Number 4, transrectal ultrasound. And number 5, ultrasonomammogram. Number 6, ultrasound of the thyroid. These are very important things. These are very important things that you need to understand, that in the exam it will be asked. They will give you scenario that the patient cannot be taken for CCT abdomen and you are suspecting a uterine malignancy. So what will you do?
Abdomen.
Ultrasound whole abdomen.
TVS.
Yeah, then you will do TVS. If the imagings are not mentioned, they will mention the tumor markers like CEA, CA121,
99.
CA199. So they
Okay,
will
sir.
give you, yeah. So then they will give you such answers. Is that clear? So whenever a patient of dermatomyositis is there, they are not asking you dermatomyositis. Everybody will remember those 5 cardinal signs, but they will ask you as a doctor, what will you do next? Okay. So the patient will have proximal muscle weakness. The poem is, cannot comb the hair and cannot get up from chair and cannot climb a stair. So these are the presentations which are mentioned in the exam, that the patient cannot comb their hair, cannot get up from chair, and all these things they will be mentioned. There will be difficulty combing hair, raising arms, rising from chair, dysphagia, dysphonia. There will be shawl sign on the chest, back, shoulder, heliotrope rash, that is this rash on the face. This is heliotropic rash. Gotron's papules are on the knuckles. This is there will be Gotron's papules here. Mechanical hands, thick skin of the palms and hands, that will be there. Labs, very important in the exam, you will see elevated CPK total. This tells you about the muscle damage, myonecrosis or myodamage. CPK-MB can also be elevated, aldolase can be elevated, LDH can be elevated in malignancies, in polymyositis. So characteristic antibodies are anti-Jo. Very important, they are tRNA synthetase antibodies, anti-Jo. Then SRP can be present, which is specific for polymyositis, anti-SRP. Signal recognition particle, anti-SRP, specifically for polymyositis. Anti-MI2, this was question asked, which of the following antibodies will not be present in a patient of dermatomyositis? So RA factor will not be present, anti-CCP will not be present, anti-RO-LA will not be present. Which will be present are mentioned here. ANA overall will be positive, anti-Jo1 is specific, anti-SRP is for polymyositis, and MI2 for dermatomyositis. It is very, you need to remember them by your heart.
Sir,
Muscle biopsy.
so anti-Jovan is specific for polymyositis.
Yes. Anti-SRP.
Anti-SRP.
Yeah. Anti-Jo is basically can be present in anti-synthetase syndrome also.
Okay. Okay, sir. Thank you.
Okay. So muscle biopsy, gold standard to differentiate between inflammation, non-inflammation, and differentiate between dermatomyositis and polymyositis. Unless you do biopsy of muscle, nothing is going to be found. Here is the differentiation. We've already done that. Electromyograph, things of the past. You will not even see in the exam. They will not mention EMG anywhere. Imaging to screen for internal malignancies. Wow. This is what I was telling. So, this is a vital part of the workup that you need to do the imaging to screen for any internal malignancies. Ultrasound abdomen, plus minus pelvis, with PSA, with CT chest, CT abdomen. Management approach, all the patients should be started on high dose steroid pulse therapy. So pulse therapy is the first line management. You give 500 to 1000 milligrams of methylpred for 3 days and then continue on oral steroids, eventually on azathioprine and antimalarials. Wherever skin is involved more, like in dermatomyositis, skin manifestations are helped by antimalarials. Methotrexate, azathioprine for refractory disease and prevention of recurrence after steroid taper. Cardiomyopathy is the major complication. Is it clear, dermatomyositis and polymyositis? I think I might be having questions for these. Must be NAPLA. Okay. So here are two questions for you. A 45-year-old woman presents with progressive weakness in her shoulders and hips over the past 3 months. She reports difficulty rising from a chair, climbing stairs, or lifting objects above her head. She denies any pain, but has noticed that her muscles feel weak and fatigued. On examination, there is symmetrical proximal muscle weakness, but no sensory deficits. Her CK level is markedly elevated, and EMG reveals irritability and fibrillation potentials. Muscle biopsy shows endomysial inflammation with CD8 positive cells. What are we dealing with? What are the catch points?
Polymyositis.
What are the catch points? Catch points.
Endomysial and increase
Proximal muscle weakness.
If CPK is not mentioned, aldolase might be mentioned. Okay. The answer is polymyositis. So polymyositis. These days, there is a trend in MRCP exams that they don't mention polymyositis, they don't mention dermatomyositis, they don't mention inclusion body myositis. What they mention is inflammatory myopathy. This is the new term. So if in the question you don't find direct answer, look for inflammatory myopathy as the answer. Is that okay? This is something recent. I don't know why they have shifted like this. So you may not find answer like polymyositis or dermatomyositis. You will say this is the answer, but then it is not there in any of the choice. So the answer will be inflammatory myopathy. So polymyositis is now classified as IIM. that is idiopathic inflammatory myopathy. So idiopathic inflammatory myopathy, progressive symmetrical proximal weakness with usually without pain, primarily affects shoulder and hips, making it difficult for patient to perform. Features: diagnostic feature include elevated CK, abnormality on EMG, endomysial inflammation with infiltration by CD8 cells. Unlike dermatomyositis, there is no rash and no inclusion bodies are seen as in the inclusion body myositis. So important things, just to make you remember, anti-Jo antibodies are seen in polymyositis. Anti-Jo antibodies, they have high predilection for ILD in polymyositis. This is very important, very important point, that anti-Jo antibodies, they indicate that the patient may have ILD. Second, anti-SRP and MI2, they are less specific, but they can be seen in anti-SRP in polymyositis, anti-MI2 in dermatomyositis. Okay, these are the differential diagnoses that we did not cover there. In dermatomyositis, there will be characteristic skin rash. Inclusion body myositis, there will be features of both proximal and distal muscle weakness. This is differentiating point, usually asymmetric, and there are rimmed vacuoles on the biopsy, that is inclusion bodies. Myasthenia gravis typically presents with fluctuating muscle weakness, worsens with the day and activity, often affecting ocular muscles, that is known as ocular myasthenia. Then hypothyroid myopathy, again very important, presents with muscle weakness. Elevated CK can be seen there as well, but there will be other signs of hypothyroidism like bradycardia, dry skin, constipation, increased sleep, decreased appetite, weight gain. Okay. All right. So now coming to another big wig of the MRCP exam, antiphospholipid syndrome. Antiphospholipid syndrome is usually about a female with obstetric failures or bad obstetric history, with history of DVT or pulmonary embolism, with a distinctive rash on the legs known as livedo reticularis. And many times you will also be given the set of antibodies, that is anti-beta-2 glycoprotein, anti-phospholipid antibody, this lupus anticoagulant. So they will be mentioned. So you need to remember their names. Classical presentation will be like this. And then they will be asking you the treatment. So the classical treatment is lifelong anticoagulation plus aspirin. This is latest, that you have to add aspirin to warfarin. And if the patient wants to become pregnant, they need to continue aspirin and take injectable low molecular weight heparin throughout the pregnancy. It is an autoimmune disorder often associated with SLE, but not necessarily. Characterized by thrombosis and recurrent spontaneous abortions. Females are more involved than male. Certain drugs can do, the drugs that cause drug-induced lupus like procainamide, isoniazid, hydralazine, oral contraceptives, and underlying malignancies. The autoantibodies are a plethora: lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein. They react against platelet membranes, leading to activation of endothelial cells, leading to complement-mediated thrombosis. So if they ask you what is the mechanism of action or mechanism of disease in a patient of antiphospholipid syndrome, the answer is complement-mediated thrombosis. The features are clots. You can remember this is the mnemonic. Coagulation, libido reticularis, obstetric issues, thrombocytopenia, and antibodies. Which antibodies? Number one, lupus anticoagulant. This prolongs the dilute Russell Viper venom test. Very important, many times asked. Prolonged APTT not corrected by normal platelet-free plasma addition. It is not corrected. Anti-beta-2 glycoprotein, both IgG and IgM, and anti-cardiolipid, both IgG and IgM. Diagnostic criteria, more than one clinical, more than one laboratory. Clinical is anything from clot, that is thrombosis, spontaneous abortion, premature birth, more than 3 spontaneous abortion before 10 weeks. This is very important. Spontaneous abortion more than 10 weeks is one criteria, less than 10 weeks, but it has to be more than 3. So, if it is more than 3, but before 10 weeks have set in, that is first trimester, very early abortion, it needs to be more than 3 episodes. Laboratory testing positive for lupus, anticoagulant, anticardiolipin. Treatment, warfarin for non-pregnant patients. Prevention of thrombosis, INR target is 2 to 3. Aspirin plus unfractionated heparin for pregnant patients and to prevent pregnancy loss. Complications are pregnancy loss and stroke. What kind of stroke? Usually
ischemic stroke.
CVT.
Usually CVT.
Venous.
Venous thrombosis. Okay. Very important. Polymyalgia rheumatica, giant cell arteritis complex. Many patients come to you, usually aged more than 50 years, females, complaining of pain in the shoulders and stiffness all the day and elevated ESR. Negative RA factor. Negative ANA. They have a condition known as polymyalgia rheumatica. It can be associated with giant cell arteritis only in 1/5 of the patients, not all. It is not a dictum. It is not a mandate. Features, muscle pain, stiffness, neck, shoulder, pelvis for more than 2 weeks, stiffness more in the morning, difficulty in getting out of the chair or lifting arms above, constitutional low-grade fever, weight loss, fatigue, all of them can be there. If there is temporal headache or MRCP, fugax, this indicates involvement of the ophthalmic artery. ESR, CRP elevated, CPK normal, absence of antibodies, EMG also normal, muscle biopsy normal. So this is PMR. Treatment, steroids. Sometimes all we give is a trial of steroid. One of the diagnostic criteria. You give the patient 0.5 mg per kg prednisone and the patient tells you that within 3 days she has improved 100%. The answer is PMR. Response is usually rapid. If patients do not respond to low-dose steroids, the diagnosis is wrong. You are treating something else. It is not polymyalgia rheumatica. You can add methotrexate to the treatment and you can add hydroxychloroquine. That is a good drug in patients in whom steroids are contraindicated or can be. Complications are blindness, which can be caused by giant cell arteritis. Now, if the patient has come with MRCP, fugax, or decreased visual acuity, the treatment is 1 mg per kg oral prednisone or intravenous methyl prednisone immediately. You can take a temporal artery biopsy within first week. Do not delay the steroids because you want a biopsy. Do not delay steroids. Give steroids or else vision loss is
Imminent.
Permanent. Yeah, imminent and permanent both. Okay.
Biopsy, we need to take skip lesions are more common. Multiple.
Yeah. So nowadays you can do an ultrasound Doppler of the temporal artery, and the biopsy, as you rightly said, is not confirmatory. Why? Because of skip lesions. There are chances that you did a biopsy and you found a normal area. Hence, long segment biopsy is preferred. Okay.
Okay.
I don't think if I have question on polymyalgia rheumatica. I don't think I have polymyalgia rheumatica questions. But then it is definitely associated with giant cell arthritis. All right. What is the next topic? Osteoarthritis we will do later. First, we will do septic arthritis. Have we already done septic arthritis? No? Or yes?
I think we have done so. Most common is staph aureus. I think we have done so.
No, so we haven't covered.
Say again?
We haven't covered septic arthritis.
No, we haven't. We haven't. Yeah. Okay. So septic arthritis is a medical emergency. It is a medical emergency. So you have to act very fast. It is caused by infection within the joint. If there is no infection in the joint, but infection is directly associated with arthritis, this is known as reactive arthritis. Then it is HLA-B27 positive. That is reactive arthritis. But if the infection is found within the joint, it is septic arthritis, and it is a medical emergency. Why? Because it can cause rapid destruction of the joint if not treated promptly. So it is important to differentiate from other causes of acute joint pain and inflammation. What is the investigation of choice?
Aspiration.
Arthrocentesis, yes. Which are the common pathogens? Staph aureus is the most common reason in adults and children. Streptococci is the second most common. Neisseria gonorrhoeae, usually seen in sexually active young adults. Other bacteria like gram-negative bacilli like E. coli. These are seen usually in patients of uncontrolled diabetes, CKD, on dialysis-dependent patients, so on and so forth. What are the routes of infection? Usually hematogenous spread. This question has been asked many times. This is the most common route. The direct inoculation is also there, but remember, hematogenous is the most common. Never confuse. Contiguous spread is from the skin and bones. Joint damage is rapid because the bacteria eat up the cartilage and bone due to release of enzymes by both neutrophils and bacteria. Acute onset of joint pain, swelling, movement is restricted, fever and chills are there, the joint is red, the joint is hot, and the joint is frozen. Okay? So red, hot, and frozen joint is septic joint, or it is gout. Okay? The knee is most commonly involved. Other hip, shoulder, ankle may also be less commonly involved. Investigation of choices, arthrocentesis. Synovial fluid analysis. From where do you take? You take it from the synovial fluid inside the joint. Essential for diagnosis. Obtain the fluid for analysis. It can be like pus, turbid, with elevated count like more than 50,000 cells, predominantly neutrophils. If you are lucky, you can find a positive gram stain and culture. Lab tests. Blood culture are positive in about 50% of cases. inflammatory markers like elevated ESR and CRP. X-ray may show joint effusion. Ultrasound MRI are helpful these days for guiding aspiration and identifying the joint fluid. Flakes can be seen floating inside. Two types of therapy, empiric and definitive. Immediately start the antibiotics. What antibiotics? Vancomycin for staph and third generation cephalosporin for gram-negative. This is the usual combination. Vanco plus monoceph. Oh, sorry. Ceftriaxone. Plus aminoglycosides can be added. That is amikacin or gentamicin. If nothing is helping, drain the joint. If there are flakes and it is a delayed case, then drain the joint. Arthroscopy or open, both, depending on the joint involved and response to the initial treatment. High yield points for MRCP. Prompt recognition is the key to prevent irreversible joint damage. Empiric antibiotic coverage is important to cover staph aureus and gram-negative bacilli. Vanco plus ceftriaxone or third generation cephalosporin. Repeated joint aspirations may be needed for persistent effusion. Gonococcal arthritis is in sexually active people with migratory polyarthralgia. Very important. Migratory polyarthralgia. Differential diagnosis: gout, pseudo-gout and reactive arthritis. A 35-year-old man with left knee acute onset pain, swelling and fever, history of IV drug abuse, synovial joint fluid analysis shows turbid fluid count of 1 lakh cells, 90% neutrophil. What is the most appropriate initial management? Oral antibiotic, IV antibiotic and joint aspiration, steroids and NSAIDs. What is the answer?
Intravenous antibiotic and joint aspiration.
Absolutely correct. शमशेर मैंने क्लास ले रहे हैं तो करता हूँ कोई इमरजेंसी तो नहीं है ना ठीक है ओके A 27-year-old woman with history of multiple sexual partners presents with migratory joint pain, tenosynovitis, pustular skin lesions. Synovial fluid analysis is negative for organisms on gram stain. What is the likely diagnosis?
Gonococcal arthritis.
What are the indicators? Negative. Usually the synovial fluid can be negative also in case of, because you see diplococci, you may not find all this. A 65-year-old man with diabetes presents with acute onset shoulder pain and fever. Synovial fluid shows 80,000 cells, predominant neutrophils, blood culture positive for gram-negative bacilli. Drug of choice is?
Yes.
Ceftriaxone, because of gram-negative bacteria. Practice question number 4. A 50-year-old man comes with a swollen, red, painful right knee after a fall. Synovial fluid shows 30,000 WBCs. Gram stain is negative. What is the next best step in the management? Start broad spectrum antibiotic, perform joint lavage and debridement, obtain synovial fluid culture, administer steroids. Synovial fluid analysis, 30,000 cells. So it has to be more than 50,000 cells to be made a septic arthritis. So septic to nahi hai. Painful right knee after fall. So possibly traumatic hemarthrosis. Perform a joint lavage and debridement, obtain synovial fluid. These are the two options through which you will reach the answer. Initially, to establish a diagnosis, you will do a synovial fluid culture. So 30,000 counts, could be septic, could be traumatic, or traumatic turned septic, anything. So you will do start the empirical antibiotics, but obtain a synovial fluid culture result. Is that okay? A 70-year-old woman with fever and hip pain. She has a history of osteoarthritis. Synovial fluid shows 60,000 WBCs with 80% neutrophil. X-ray shows no obvious joint effusion. What is the most sensitive imaging modality for early detection of joint involvement in septic arthritis? The answer is MRI. MRI is the most sensitive imaging modality for earliest detection of joint effusion and other changes associated with septic arthritis. Is that okay? We have 15 minutes to go. Can we cover vasculitis in it? No, I don't think so. Be too much information for you to digest. Okay, we'll do osteoarthritis. Osteoarthritis, degenerative disease. Most common joint disease due to softening and degradation of synovial cartilage and slowly secondary changes to the adjacent bone. Women and elderly are more prone. Your usual risk factors are obesity, trauma, repetitive use of a joint, age, female gender, family history. It is basically a wear and tear which has gone wrong. The periarticular muscle, it weakens, cartilage gets destroyed, bone gets remodeled. So eventually, pro-inflammatory cytokines will come in, leading to pain. Stiffness usually doesn't happen, but if it happens, it is usually after the joint has been used for quite some time. It is a non-inflammatory, but eventually it will attract inflammation. These are the degrees of joint involvement in osteoarthritis, stage 1, 2, 3, and 4. You see here, eventually the cartilage is lost and the bone directly touches the other side of the bone. So joint space greatly reduced, 60% of the cartilage is lost. Large osteophytes are there. Bones get chipped off and these chips are scattered inside the joint space. Pain is there, which worsens with the use and improves with the rest. Commonly hands, hips, knees are involved. Joint tenderness is there. Decreased range of motion is there. There are certain telltale signs of bony swelling. If the distal interphalangeal joint swells up, it is known as Herberden's nodes. If the proximal interphalangeal joint swells up, it is called Bouchard's nodes. Base of the thumb, first metacarpal joint is the most common and first joint involved. Hips, knee, and spine being the other ones. So, you see both of them here. Sorry. Yeah. Which are these nodes?
Bus node.
Shepardon's nodes.
Which are these nodes?
Bouchard's nodes.
Okay. Radiography will show osteophytes. Again, remember hook osteophytes are characteristic for
Hemochromatosis.
joint mice subchondral sclerosis. Subchondral sclerosis. Look for this term and the diagnosis is osteoarthritis. Labs, CRP and ESR, they are always known. Conservative strategies to treat are weight loss, exercise, stop smoking, use topical or oral non-steroidal drugs, and of course surgery. Pearls for MRCP that you need to remember. These will keep coming again and again. If metacarpophalangeal joint is involved in osteoarthritis, it suggests a secondary cause. Remember, it is the PIP,
Proximal interphalangeal.
Bouchard, dip, burden, but MCP is not mentioned unless it is the first MCP. But if it is, then it is a secondary osteoarthritis, usually due to CPPD. This is very important. Second, diagnosis is made clinically, age more than 45, activity related joint pain, morning stiffness that is less than 30 minutes. Two types of OA, primary and secondary. Primary can be localized to hip and generalized to multiple joints can be there. Burdens and Bouchard's indicative of primary generalized osteoarthritis. This is very important in true and false. They will ask you which of the following statements is true. So this will be mentioned there and that is true. Trapeziometacarpal joint, TMC, or the base of the thumb is the most common site of beginning of osteoarthritis. Nice guidelines. Paracetamol and topical NSAIDs. Remember topical NSAIDs. When I was preparing for rheumatology, like 10 years back, I made a mistake in this question. There was an option of topical diclofenac and I ignored it. The answer is this. If paracetamol oral is not mentioned in the exam, don't go for oral diclofenac. Go for topical diclofenac as the answer. Okay? Topical NSAIDs are only for osteoarthritis of knee or hand. Second line treatment is oral NSAIDs, where diclofenac will come. So first line is topical. Second line is oral. COX-2 inhibitors like etoricoxib, celecoxib, opioids, tramadol, capsaicin cream, and intra-articular steroid. Glucosamine is no recommendation from NICE guidelines. Okay. Khatam ho gaya. So that is osteoarthritis. We have still 5 minutes. Can we do reactive? Because reactive
Yes, sir.
And psoriasis, we should do together, okay? So I will take extra time today, maybe 5-10 minutes, but we will cover both reactive and psoriasis. So remember, there are conditions known as seronegative spondyloarthropathies. What do they have in common? Number one, they involve the axis of the body. Number two, they involve the peripheries of the body. Number three, they are seronegative. That means they are RA negative, they are anti-CCP negative, they are ANA negative. So what are they positive?
B27.
They are HLA B27. They are 4 types, P, A, I, R. Normally pair is 2 things, but here there are 4 things. One is psoriatic arthritis, ankylosing spondylitis, IBD associated arthritis, and reactive arthritis. They can have extra articular symptoms as well, like eye involvement. Very common. Genital involvement, oral involvement, skin involvement. Is that clear? MRCP people, they are very clever. Sometimes in the options, they write irritable bowel syndrome related arthritis. That is a wrong answer. Sometimes they say bowel related enthesitis. That is also one of the features of these 4 diseases. That is 6 number is presence of enthesitis. What is enthesitis?
This
Joint space infection.
This is
No.
tendon
Tendon.
inflammation.
inflammation at the tendon insertion.
Tendon insertion inflammation. Okay, this is very important. Sometimes the patient can have only enthesitis. Is that clear? What I just told you about seronegative spondyloarthropathies, axis, that means spine and sacroiliac joints, peripheries like rheumatoid arthritis joints, small joints, wrist. Seronegative, RA negative, anti-CCP negative, ANA negative, HLA-B27 positive. 4 conditions: psoriatic, ankylosing, IBD associated, not IBS associated, and reactive arthritis. Extra articular features of skin, oral, eye, and genitalia involvement. Sometimes vessels like aorta. Then enthesitis. I'm sorry if it is too much of information, but then it is important. And if you have read about it, you will be enjoying it because it is very, very, very interesting. I to love it. So reactive arthritis, again, like rheumatoid, it is a systemic inflammatory disorder. Results from extra articular infection, usually a sexually transmitted or diarrhea. Typically after 1 to 6 weeks of infection, so no bacteria can be found in the body. Earlier known as Reiter's syndrome. Triad is urethritis, conjunctivitis, and arthritis. 20 to 40 years, reproductive age group. Following a urinary infection, more common to develop reactive arthritis in men, not in women. Affects men and women equally when a GI infection is the culprit. Risk factors: HLA-B27 positive, genitourinary pathogens like chlamydia and Neisseria can lead to reactive arthritis. GI pathogens like Salmonella, Shigella, Yersinia, Campylobacter. MRCP people are so notorious. Once they asked which of the following GI bacteria do not cause reactive arthritis, and the answer was E. coli. Anyhow, that is how they do it. So these answers were all there. Most cases will recover spontaneously. Clinical features: arthritis, it is an arthritis, typically acute and asymmetric oligoarthritis. Knee, ankle, heel. Eyes, conjunctivitis. Genital involvement: circinate balanitis, urethritis in female, cervicitis. In skin, keratoderma balanoragicum, usually mentioned as necrotic, dirty looking, hyperkeratotic also, lesions on palms and soles. This is what is mentioned in the exam. They will not show you photo. This is what will be mentioned. In labs, there will be TLC will be elevated with neutrophil predominance, ESR, CRP elevated. Treatment: chill. Only give NSAIDs, diclofenac, aceclofenac, fine, no antibiotics. If you want to give, you have to prove if the infection is still present. If they are present, then you give it. Complications: notorious, aortitis and cardiac. Both of them can occur. After reactive arthritis, psoriatic arthritis, seronegative spondyloarthropathy, presenting with 5 patterns of arthritis: asymmetric oligo or asymmetric monoarticular arthritis. Sorry, asymmetric oligo or monoarticular. Affecting dip. Very important. I told you in rheumatoid arthritis, if dip is involved, it is not rheumatoid arthritis. So dip predominant arthritis, arthritis mutilans, symmetric rheumatoid factor negative polyarthritis, psoriatic spondyloarthropathy. 5 to 20% of psoriasis. Genetics, HLA-B27 in 50%. This has come in the exam. Even I guess IBD associated arthritis is associated with 40%. That is also has come in the exam. Clinical feature, arthritic symptoms in the hands, rash with silvery exfoliative rash on the extensor surfaces, maybe scalp. Typically precede joint involvement by several years, 80 to 85% of the times. Dactylitis, sausage disease, you can see that. This photo is actually of one of my patients. Sausage shaped. Onychodystrophy, their nail pitting is there, onycholysis is there, and then arthritis mutilans, opera glass hands. What happens is, this is how the fingers looks like. Because the joint has been eaten up, literally. So excess skin from shortening of the phalanx becomes folded transversely, leading to retracted into another glass like opera glasses. I'll show you. It is penicillin cup on X-ray. So in X-ray, what you see is, this is the joint. It has been eaten up, and the upper joint is like this. So this is penicillin cup. Chronic uveitis, even acute uveitis can occur, but chronic uveitis is very common. Enthesitis of Achilles, posterior tibial plantar fasciitis can be a, see, so beautifully seen as pencil in cup deformity here. So it is DIP arthritis, which is seen as pencil in cup. There will be small joint erosions or fusions. Ankylosis occurs. Fluffy periostitis. Fluffy periostitis means the fingers will be puffy, typically sausage finger. Acrosteolysis, that is, the distal phalanx is sometimes eaten. All you have is like a sausage. Sausage has a knot here. So it looks like this. The distal phalanx is lost. It is gradually resolved. Flailed digits. The criteria are Casper's criteria. That is, psoriasis or family history of psoriasis, 2 points. Typical nail dystrophy, 1 point. Negative RA factor, 1 point. Dactylitis. Dactylitis is not seen in any other disease of rheumatology, but psoriatic. Radiographic evidence of new bone formation, 1 point. Score of 3 or more confirms psoriatic. The criteria is Casper. Spine and axial disease, sacroiliitis, syndesmophytes, paravertebral ossification, destructive discovertebral lesions. Treatment, NSAIDs, methotrexate, sulfasalazine, cyclosporine, and the drug, wonderful drug, adalimumab. Very good drug. Nowadays, it is so famous that MRCP is asking the dose. So the dose is 40 mcg every 2 weeks. Subcutaneously, like insulin, given at home. What is your home workup? First of all, rule out tuberculosis, rule out HIV, rule out hepatitis C, rule out HBs antigen. Once you have ruled out these 4 major diseases, you can start the patient on adalimumab. Excellent drug, very good recovery, and the patient can go on to take it for years together. Every 2 weeks, 40 micrograms. Operative, you can remove the digits which are not automatically removed. Remember, HCQS is not indicated as it can itself worsen the skin lesions. So when in doubt, whether it is rheumatic or rheumatoid or psoriatic, just start with methotrexate. All right. Reactive and psoriatic arthritis for you. Next time, I will start with the questions for both of these, and then we will go on to read ankylosing spondylitis. Septic we've done. And of course, relapsing polychondritis. Nowadays, those people who are appearing in winter session will get relapsing polychondritis questions. Sjogren syndrome. And of course, the last but not the least, vasculitis. So only 4 topics left. We will cover them in the next class. Is that okay? Any questions?
Question that how long this allopurinol should be continued in case of gout?
How long?
Allopurinol is continued for prevention of gout or for maintenance of gouty symptoms.
See, the target, when the target is achieved and the patient is asymptomatic.
Okay.
So what is the target?
Less than this 300, 300,
350. Yeah.
350
Microgram. Yeah.
microgram.
So basically, if the patient has chronic gout like Lichtenstein syndrome or Kelly-Siegmüller syndrome, then you will need to continue for life. But then you have to understand, many times the patient, once you treat the patient, hyperuricemia is usually because of some drug they have taken, which has decreased the excretion of uric acid, gout precipitates. And once you give NSAIDs or colchicine or allopurinol for about 3 months, it goes away. There are no clear-cut guidelines, but then when the patient gets okay, you should stop.
Oh, thank you.
In
Excuse
kidney
me, sir.
disease, in chronic kidney disease, you might need to give it lifelong because excretion is not
Excuse me,
happening.
sir.
Yes?
Sir, can you tell again the treatment of osteoarthritis in elderly patient?
So as far the guidelines are concerned, the osteoarthritis treatment will begin with paracetamol and local NSAIDs. The first thing is paracetamol and topical NSAIDs. Then comes oral NSAIDs.
Look,
Yeah, like COX-2 inhibitors or
is there any role of steroid in osteoarthritis?
no. Steroids can decrease
Has
inflammation.
steroid any role?
No. Steroids have no role.
Okay.
Steroids have no role.
Thank you.
They are not mentioned anywhere. So remember, I'm
Even
again telling you.
osteoarthritis,
I'm telling you.
NSAID is
The first drug is paracetamol. First drug is paracetamol. If the patient does not want an oral, it is only localized hand disease, then go for topical non-steroidal anti-inflammatory drugs. Okay? If the patient is on topical and oral paracetamol, then you start the patient on oral non-steroidals or COX-2 inhibitors. If the patient is still not improving, then topical capsaicin. If the patient is still not improving, then oral opioids. If the patient is still not improving, then joint replacement. Of course,
sir,
listen. If of course, if the patient has lot of pain, and it is severe, then it is because of the debris, the debris of the cartilage, which is scattered inside the joint fluid. So intra-articular steroids you can give. You can give intra-articular steroids, but oral steroids, no. You cannot give. There is no indication.
okay, sir. Sir, we all know the side effects of NSAIDs.
Yeah.
How long we can go for NSAIDs?
The last patient I reviewed who had come from UK was for last 3 years on naproxen 500 milligram daily.
Okay.
So there is no guideline. If somebody can tolerate with PPI, they can go on having it.
Okay.
Sir, any role?
Thank you.
Yes.
Role of chondroitin sulfate in osteoarthritis?
No. The only hyaluronic acid injections are approved in NICE guidelines,
Okay,
but even those have been taken away now. Now there is no recommendation.
Thank you,
Okay,
sir.
sir. Thank you. Thank you very much.
Yeah, in the NICE, in NHS, they do give injection of hyaluronic acid, but NICE does not approve of it as of now.
Okay.
Okay. Thank you, sir.
Okay.